Hello, everyone, and welcome to today's Center for Healthcare Strategies webinar titled Expanding Access to Community Health Workers in Rural Communities. I am Megan Terrell, a program officer at the Center for Healthcare Strategies. I'm excited to welcome you to today's session. Today's webinar is a product of CHCS's Evidence to Action Hub, made possible with funding from the following organizations: Arnold Ventures, Commonwealth Fund, the Johnny Hartford Foundation, Peterson Center on Healthcare, Robert Wood Johnson Foundation, and the SCAN Foundation. We thank these organizations for their support. Go to the next slide, please. Before we get started, I want to go over a few logistics for today's event. As folks are entering the webinar, audio lines will be muted to eliminate any background noise. We will be having a moderated question and answer session following presentations from our speakers. If you'd like to submit a question at any point throughout the webinar, you can do so by clicking the Q&A icon located at the bottom of the screen. We'll get to as many as we can in our allotted time. Today's webinar is being recorded and will be posted to the event page on chcs.org in the coming days, and materials will also be emailed to all registrants. Finally, at the end of the webinar, we welcome you to complete the brief online evaluation that will pop up on your screen and appreciate your feedback. You can go ahead to the next slide, please. Here's our agenda for today's webinar. We'll be focusing on expanding access to community health worker programs in rural communities across the United States. Rural Health Transformation Program presents new opportunities to strengthen this workforce, building off of the strong evidence base for community health worker services and interventions. We'll hear from experts with expertise and experience in implementing these programs in rural communities, and they'll share their learnings and infrastructure and program design considerations for programs to succeed in these areas. Following presentations from our speakers, we'll have time to respond to your questions, so thank you for sharing those with us in advance as you registered for today's webinar and throughout the session. Before I turn it over to the presenters, I want to share some more information on the Center for Healthcare Strategies and the Evidence to Action Hub. So we can go ahead to the next slide, please. The Center for Healthcare Strategies, also referred to as CHCS, is a policy design and implementation partner devoted to improving outcomes for people enrolled in Medicaid. CHCS has partnered with states, managed care plans, healthcare providers, and community-based organizations across the country to increase access to community health worker services and support the growth and sustainability of this workforce. Next slide, please. Some of the work in our community health worker portfolio is published on the Evidence to Action Hub, which I'm excited to share a little bit about with you today. The Evidence to Action Hub launched in September 2025, carrying on the legacy of the Better Playbook, which is a resource guide to advance effective person-centered care. The library of evidence roundups and collections touch on several topics and share evidence, case studies, implementation tools, and policy considerations to improve care for people served by Medicaid. You can access the Evidence to Action Hub by visiting chcs.org/evidence to action. You can go to the next slide, please. I'll take a couple moments to introduce our speakers for today's session. We're really excited to have them with us. First, we'll hear from Annie Cloak, Director of Public Partnerships at Impact Care, Bree Burke, Program Manager at the Tennessee Association of Community Health Workers, or TNCHWA, Amy Mosley, Director of Development and Community Engagement at Healing Hands Health, and Lindsay Miller, Project Director for the Connected Care for Older Adults program. Following presentations from Annie, Bree, Amy, and Lindsay, I'll turn things over to my colleague Logan Kelly, Senior Fellow at the Center for Healthcare Strategies, who will moderate the Q&A and close out today's webinar. Next slide, please. Before we hear more from our speakers today, I'd like to talk a little bit about community health workers, their impact, and how services provided by community health workers, or CHWs, are covered. Community health workers is a title that represents non-clinical professionals who have extensive knowledge and lived experience in the communities they serve. CHWs may be known as different titles, such as navigators, promotor, promotoras, community health representatives, or health advocates, to name a few. and these roles typically perform similar work. Services provided by CHWs can include education, coaching, outreach, and navigation, among others, to help individuals reach their health goals, address health-related social needs like housing and nutrition, and access preventive care. Services can be delivered in community-based settings or in a clinic or health system, and CHWs are also commonly part of interdisciplinary teams and coordinate support across both healthcare and social services providers. There are lots of studies out there that have described community health worker interventions, roles, and outcomes, and some of those of focus include reductions in hospitalization and emergency department visits, cost savings and returns on investment, improvements in the management of chronic diseases such as diabetes and hypertension, improved feelings of social connectedness in one's community and with one's care team, just to name a few. I will share that some of sources describing these outcomes in more detail can be found at the end of the presentation. Next slide, please. Historically, CHW programs have relied on grant funding and private contracts to support initiatives that typically are pilot programs, limiting opportunities to scale and sustain programs and services. In recent years, Medicaid and Medicare have emerged as sources to reimburse services provided by CHWs, and we see that about more than half of states offer Medicaid reimbursement for these services through various levers and authorities such as state plan benefits, Section 1115 demonstration waivers, and managed care requirements. In 2024, Medicare authorized reimbursement for CHW services under something known as the Community Health Integration Services benefit. Individuals with Medicare coverage may receive a referral to a community health worker for care coordination or patient self-advocacy training, as well as health systems navigation and social and emotional support activities. Billing for these services is growing as organizations identify opportunities to utilize this benefit. We received a lot of questions from registrants about how CHW services reimbursement works in different states and settings. So in response to these questions, we provided some resources at the end of the presentation to hopefully address some of those. And as we go throughout today's webinar, we'll build on this overview of community health workers as we hear from our speakers today. Now I'd like to welcome our first speaker, Annie Cloak, Director of Public Partnerships at Impact Care, to share more about how this workforce can improve rural health. Welcome, Annie. Thanks for joining us.
Great. Thanks, Megan. My name is Annie Cloak. I am Director of Public Partnerships at Impact Care. And for those of you who don't know, Impact is one of the most evidence-based and widely used community health worker programs in the country. I'm delighted to be here today to kick us off, and I'm going to be talking about why states should be integrating CHWs into strategies to improve health, especially in rural areas, how states have included CHWs in their Rural Health Transformation Program, or RHTP applications, and then also ways that states can build or strengthen their CHW workforces and programs as they implement RHTP initiatives and other policies. At the end, I'll also highlight some resources that we've developed to help states with these efforts. Next slide. So Megan did a nice job of teeing this up, but I'm just going to reiterate some of these points. But community health workers, also known as promotores and community health representatives, are a proven cost-effective workforce that can be quickly scaled and deliver an impact. Before we get into the how, again, I just want to touch on why states should be thinking about CHWs. First, they extend the workforce and increase access to care. And this is especially critical in rural areas where we know there are workforce shortages and where residents face unique barriers. Next, CHWs working within best practice models have been shown to improve health outcomes for their patients. Examples of this include A1C levels, blood pressure control, self-reported mental health, and other outcomes. Finally, the research also shows that CHWs can reduce healthcare system costs, which is essential as states and providers face spending cuts. So when you think about all of these components together, it is clear that integrating CHWs into RHTP strategies can really help states transform rural healthcare. Now let's look at how states have actually integrated them into their initiatives. Next slide. Thanks. So over 30 states, I actually think it's closer to 40, have integrated CHWs into their rural health transformation program applications in one way or another. There is quite a range in terms of what states are doing, but here are some of the themes that we've seen across applications. So first, many states have included efforts related to workforce development. This includes recruitment, training, certification, and retention strategies. For example, South Dakota will develop strategies to recruit CHWs, but they've also committed to creating career pathways and advancement opportunities to support retention. Next, a number of states will support billing or financial sustainability. One example is Wisconsin, which will pay for CHW services not currently covered by Medicaid, as the state works towards more permanent coverage policy through a state plan amendment. Some states, including Michigan, will develop billing strategies to support CHW codes. And then a number of states have included efforts to expand value-based payment models in rural areas. And I note this because there is a great opportunity to integrate CHWs into care teams under these models, given their ability to improve outcomes and control costs. Another trend we are seeing is inclusion of funding for evidence-based programs or infrastructure. 3 examples are California, South Dakota, and Tennessee that will all implement evidence-based community health worker models as part of their initiatives. And then finally, some states will launch initiatives that embed CHWs into care teams serving specific populations. So a common thing that we have seen is integration of CHWs into initiatives for individuals with chronic conditions. Other states have proposed larger scale strategies that will integrate CHWs. For example, Indiana will issue grants to regional entities. And those regional sort of transformation efforts are required to include community health workforce into much larger and broader plans. So that is just a snapshot of what we've seen. There are 50 state applications, but it is really exciting to see states recognize CHWs as part of their rural health strategies. Now let's look at what they should be thinking about as states move forward with implementation. Next slide. So here are the critical areas we recommend states focus on. And based on our experience, if you don't address all of these things, it is hard to build a sustainable CHW ecosystem. So first, CHW should be included in policy and program development early on. This allows for alignment of shared goals, as well as ensuring that policies or programs actually support the workforce and can deliver on intended outcomes. States should also look at evidence and examples of what works. So this means looking at proven programs or policies that have been shown to advance the goals or the metrics that states are prioritizing. Infrastructure is also critical. This goes beyond training and also includes best practice program design, evidence-based workflows, tools to track program impact, and systems to support billing. The right infrastructure enables CHWs to do what they do best, which is connect with patients, but it also allows states to scale and sustain initiatives long-term. Financial sustainability is also crucial. Reimbursement is very important, but policies need to be designed in a way that actually allow CHW providers to bill and get paid. And we also know that reimbursement is not enough alone. So states should also be engaging payers and providers, especially in development of value-based initiatives to ensure that those include CHWs. And then finally, as states expand the workforce and set up CHW programs, they should consider strategies to ensure program quality and keep CHWs in their jobs. And one example is program accreditation, which I know Bree will talk more about. Next slide. So Impact has created some tools to support states and other partners like CHW associations and CHWs working to develop and implement policies and programs. First is the State Plan Amendment Toolkit, which is to support states that are either developing for the first time or refining Medicaid policies for coverage and access to CHW services. If you are in this bucket, we really recommend you check out this tool. The second is Rural Health Transformation Program sample language. This was originally created to help states that were developing applications to CMS for their rural health transformation programs. But this can also be used by states as they create notice of funding opportunities, grants, requests for proposals, or other guidelines to operationalize CHW initiatives. I will wrap there. Thank you so much for your time and happy to answer questions or connect.
Thank you so much, Annie. Appreciate you spending some time with us this afternoon and sharing your expertise and resources. Next, we'll hear from more of our speakers on building effective community health worker initiatives in rural communities, building off of examples in Tennessee, Virginia, and Oregon. I'm excited to turn things over to Bree Burke, Program Manager at the Tennessee Community Health Worker Association. Welcome, Bree.
Thank you so much. Hello, everyone. As you said, I'm Bree Burke. I am the program manager for the Tennessee Community Health Worker Association. But before stepping into this role, I actually spent years working directly as a community health worker in rural communities. So I was the first community health worker in the Northeast Tennessee, Southwest Virginia area, right in the heart of the Appalachian Mountains, if you're familiar. And first, I was a CHW through a hospital system, and then for a smaller not-for-profit that provided dental and primary care to the uninsured and underinsured community members. And you'll actually get to hear from one of those, my employer at that time, in just a minute. But the boots on the ground work that I did still shapes every single thing that I do today as a CHW and as a program manager with CHWA. Next slide, please. Perfect. So I want to talk a little bit about what it's like to be a CHW in rural communities. So being a CHW in rural communities means we are never going to do the same thing twice, ever. Every client brings a new situation. They bring a brand new obstacle, brand new solutions. You're not just providing support for them, but you are constantly adapting to what needs to come next for each patient, each client you're working with. Next slide, please. So we have several barriers that we face being in rural communities. In larger cities, people often have buses, rideshare options, even down to electric scooters and electric bikes in a lot of places. But in rural towns, those simply do not exist. So transportation often becomes one of the biggest barriers that we face in rural communities. And that's whether people are trying to get to their appointments, to pharmacies, basic services. There's all kinds of things that they need to get to, but transportation is not optional in our areas. So just a quick example, I had a client who was elderly that did have Medicaid, so they did have a couple of Medicaid rideshare options, but they used them all up within the first 6 weeks of the year, and so they didn't have anything for the rest of the year. So it was really important for CHWs to step in and be like, how can we bridge this gap? What can we do to help fix this? Because transportation is such a barrier that we face. This individual, we were actually able to get connected to some churches and different things, and church buses would pick her up and take her to the grocery store, to her appointments, doctor's appointments, dental appointments, everything that she needed. But it was so important that we were able to connect to those different things because transportation is it's a huge need. And of course, if they can't get to where they need to go, they can't stay the happiest and healthiest version of themselves, which is what we're trying to do. Resources are harder to find in rural areas as well. So even though they do exist, a lot of times people may avoid them in fear that they might know whoever is providing the resource or that somebody else in the community might find out. So privacy concerns and stigma play a huge role. And CHWs are often that bridge that help people feel safe accessing that support. I don't know if anybody on here listens to country music, but that song that says everybody knows everybody, everybody calls me friend. Well, when you live in a rural area, you're going to know most everybody. Or if you don't know them directly, you're going to know somebody that knows them. So a lot of times they won't go get the help that they need because there's still stigma behind it. They don't want people to know. Another example I can give you is I worked with a client that lived without electricity for 2 years because they were having financial issues. They didn't have any more family members that were living. And they didn't want anybody to know that their financial struggles had gotten so bad and some substances had been picked up where they were just lonely. Working with them, I was able to get them connected to some things, was able to help them keep a lot of their information private as they wanted, but able to get their electricity back on and things that they needed. But a lot of times that stands in the way. It stands in the way of a lot of our clients and getting what they need. Another thing is telehealth. It can be incredibly helpful, especially during COVID and in rural areas, not being able to get to a hospital. But that is only if there's reliable internet or if people understand how to use telehealth. So many of our rural areas still do not have any kind of internet service, or if they do, people just don't understand how to tap into it. So CHWs often spend significant time helping clients navigate technology just to access that basic care, but also teaching them, how do I utilize telehealth? How is this important? Why would I need it? And in being able just to open up apps on their phone so they do know how to use it. All right, next slide, please. So I've said a lot of things about what I've done as a CHW, and I love that work so, so much. Today, in my role with Tentua, I get to pour into CHWs across the state. So I said my boots on the ground work still funds everything that I do right now as far as being the manager or the program manager for Tentua. I get to work with CHWs from our biggest cities in the state of Tennessee to our most rural counties. So I make sure that they have tools, training, support, everything that they need to succeed. We do at Tentua have our own training program. We're actually trying to tie up some loose ends from a previous program through our partnership with Vanderbilt University and Rural Health Association through the HRSA grant we received. And we're launching our brand new training program, hopefully by the end of spring. Our CHW training program focuses on sharpening the natural skills CHWs have, because when you're hiring CHWs, you have to look for all of those natural things that they already have. You have to look for that empathy, love of community, being able to listen, really hear people. You have to listen to all of those things, but our training program helps sharpen those skills. So not only are they using what they already know and those lived experiences, but they're able to sharpen them up and really kind of get everything tuned in the way they need to be the best CHW they possibly can. Next slide, please. Another program that we offer through Tentua is not one that I actually manage, but it's something that is very near and dear to my heart, and I've actually advocated for this for a long time. It's the CHW program accreditation. So Tentua has been able to partner with TennCare, the state Medicaid office, and the National Committee for Quality Assurance, which is the NCQA, to pilot a CHW program accreditation, as well as partner with Impact to oversee the sites being accredited to ensure that they are preparing for accreditation appropriately. So this program focuses on accrediting the program and not the individual CHW. Accrediting CHW programs will ensure that the agencies are meeting standards that are centered on best practices that develop quality programs. Also, it highlights the work many CHW programs in Tennessee have already been doing for years. What we are excited about with this is we're making sure that CHWs are able to do their work, and it's not going to be over medicalized. It's not going to turn into something that it's not. We're making sure that the programs are set up to where they can be successful. They're going to work on what the clients actually need, and there's not going to be any hidden agendas. We're trying to go in and make sure that that happens in our state so our programs are successful throughout the whole state. We work with CHWs, CBOs, CHW program leadership, academic institutions, hospital systems, clinics, and our state Department of Health to design 7 standards based on the C3 competencies, best practices, and academic research surrounding CHW work and quality programs. The programs must provide evidence for each of the 7 standards and must achieve a certain score under each standard to be accredited by Tentua. We have begun the actual process, and to date, we have 9 programs that's been accredited, and we are currently in cycle 2 and have 14 more programs that are undergoing this process. Next slide, please. So you can look this up actually on our website if you're interested on tentua.org. But the 7 standards, of course, as you can see here, are the recruitment and hiring, CHW scope of work, again, protecting the integrity of our work, supporters for CHWs, CHW training, CHW performance evaluation, CHW professional and workforce development, and CHW supervision, making sure that not only is the integrity of their work protected, but the surrounding of their work is protected as well. So they have the right supervisors in place. They know what needs to be happening. They have all the support that they need to move forward. Next slide, please. And I'm just going to end here. I thought it was really important for you to see the programs that's already been accredited through Tentua to date. Salome has 2 different programs. Methodist Le Bonheur Community Outreach has 2 different programs they've accredited. We have programs through the Mental Health Cooperative Tennessee HealthLink, Regional One Health CHW program, Senior Solutions CHW program, LifeDoc Community Health Worker program, and the Meharry Health Solutions Tennessee CHW program. And we're really excited about that. All right, I'll pass it back to you, Megan. Thank you so much.
Thanks, Bree. Appreciate your presentation. I see there's a few questions in the chat for you. If you're willing, if you're interested in answering, just giving more information about the accreditation process for a few of our attendees. So thank you again. Next, I'd love to welcome Amy Mosley, Director of Development and Community Engagement for Healing Hands Health. She'll be touching a little bit on her the CHW program at Healing Hands Health and lessons learned. Welcome, Amy, and thank you for joining.
Thank you, Megan. We can go ahead and start with the next slide. I wanted to start out by telling you a little bit about who Healing Hands is and how and why we incorporated community health workers into our program. We are a faith-based charitable clinic. We were established by a group of churches in 1997 to address gaps to access and care for people who are uninsured and underinsured in Northeast Tennessee and Southwest Virginia. As you can see from the map, we serve approximately or usually around 21 counties per year. And we are located right in Bristol, Tennessee, which sits directly on a state line. Our downtown is actually divided by a state line, so it's very interesting. It provides a lot of challenges to serve patients from both sides of the state, especially when dealing with Medicaid and dealing with safety net funding. But it also provides some opportunities for different types of funding models and learning things from different states. So there's good and there's bad to it. We are not, where our clinic sits is not directly in a federally designated rural community, but many of our patients are from those rural communities. We provide medical with integrated behavioral health, dental and vision care, along with supportive services. And our mission really drives how we engage and design those programs. We really want to provide our patients with dignity, trust, and long-term engagement in their healthcare. Next slide, please. Our first experience with community health workers was with a partnership with our local hospital system, Ballad Health. They offer to have a community health worker embedded in our clinic, and that is actually, at the time, was Bree, who you just heard from. This was back when she was a community health worker, and we really did not know much about community health workers. This was in 2020. We didn't start having community health workers in our area until about 2018, so this was a pretty new concept to us. Once Bree was here and we saw the magic, I call it the CHW magic, we were really sold and saw what this program and having community health workers could really do for our patients. We learned very quickly that access issues are rarely just clinical issues. For many of our patients, especially those living in rural areas, the barriers are transportation, time off of work, understanding the healthcare system, and sometimes past experience have made them hesitant to engage in care. You know, they run into frustration because either they could not find someone to see them, especially if they were uninsured, or if they were eligible for TennCare or Virginia Medicaid, they weren't sure how to access it or to find a provider, or once they find a provider, to get to the provider. So the community health workers really help address those gaps. And they are able, you know, they come from the community they serve, which if you are new to this community health worker strategy, you really want to find people who are from that community so that it builds the trust with the patients. And they are totally then integrated into our clinic. We quickly learned you can't have the community health workers working in a silo. They need to be completely integrated into the care team and have regular meetings with our dental team, with our medical team, so that everyone is working hard to help that patient. They have allowed our providers, this is one of the most beautiful things I think about it, they have allowed our providers to work to the top of their license. We have run into, for a long time, our providers told us, you know, we really need a full hour, especially with the new patient, because many have not seen a provider in years and there's a lot going on. But a lot of what they were addressing during that time had to do with social determinants of health. Now, with community health workers on our team, they are able to, the provider can handle the medical, the dental part. They can do a warm handoff to community health worker. Community health worker can work on the social determinants of health. And this has allowed our providers to have shorter appointments and be able to serve more patients, which is really critical in rural areas where we do not have enough providers to begin with. Next slide, please. And at Healing Hands, so like I said, they are employed members of the team. They work across services and not in silos, and their role is focused on coordination. This is especially important in rural communities where services are fragmented and patients may be traveling across counties or even state lines. One of the biggest lessons that we learned early was that CHWs only work when they are truly integrated. Our CHWs participate in team meetings, have clear workflows with providers and staff. They are not just operating on the margins. And while they do a lot of community outreach, they are also doing direct patient care. They usually carry about a 15 to 20 patient caseload in addition to doing community outreach to get people more engaged and to let them know how to access services at Healing Hands. One of the big things that we found, and this does not come easy, especially in the early days, provider buy-in is critical. When providers understand how CHWs support their work, the referrals will increase to the CHWs, communication improves, and patients are more likely to stay engaged. So it's really important if you're thinking about adding community health workers to your team that you really engage your providers and get them on board and help them to understand what it is that the community health workers can do for their patients. Once they see that, it clicks and they would never want to do away with them. But it takes a little time, depends on the provider and if they've had exposure before. Next slide, please. So from my perspective, being the director of our community health worker program, and I'm also our director of development, so fundraising, I find that funding for community health workers is really the hottest topic right now. We have all seen anyone who's really worked with community health workers and seen the work that they do has really seen how important it is and that they are bringing so much value. However, at Healing Hands to date, our community health program so far has been completely grant funding. But as we all know, grant funding is time limited, but the needs are not. The challenge, and this is not unique to us, is sustainability. Grant funding, like I said, it'll come and it'll go, and you don't want to be completely dependent on it. We have focused from the beginning on measurements. We work closely with Impact Care so that we can measure how we are taking care of our patients and how it's helping them so that we can have those conversations with our funders. And we've tried to align with broader system goals and stay in tune with what is going on at the state level and with Medicaid that could help us sustain our program. I just want you to just really know, though, that it is a constant battle that you're always going to be working on that until people start to become more familiar with community health workers and realize that it might be a front-end investment, but you are going to save the healthcare system and the community lots of money in the long run. To be a community health worker champion, you'll have to be willing to have constant conversations with your donors, with your foundations that you work with, and community partners on the value of community health workers and why we need to keep them and why we need to say they're part of the care team, just like a medical assistant, the person who makes the appointment, your providers, they're part of the care team that you cannot do without. Next slide, please. Why utilize community health workers in rural communities? Nationally, rural residents experience higher rates of chronic disease and preventable hospitalizations. Workforce shortages and distance to care compound those challenges. So patients have to travel further, but we also don't have enough providers often. Evidence across multiple states shows that community health workers improve access to primary and preventative care, reduce unnecessary emergency department use, and improve chronic disease outcomes. In rural settings where provider supply is limited and barriers are greater, that impact can be more pronounced. Next slide, please. Oh, so I know that Annie and Lindsay are sharing, have shared some data about the impact of community health workers. So I thought a patient story would be valuable just to really describe the magic and how this works. We had a patient recently that Sky, she's our community health manager, but she also still has her own patient load that she had. His name is Brandon, and he's been coming to our clinic for about 4 years. He's seen in medical, he's seen in dental, so he utilizes all of our services, and he comes here from a rural area. So he's been involved with us for a while. However, he started to have some pretty significant health issues with his heart. Um, and we have a health navigator also who works really close with our community health workers. She's actually employed by our local hospital system. The doctor, said we really need to get him in to see this heart doctor. And so we have something called Project Access that helps people who are uninsured be seen by a specialist. But once he went to the heart doctor, there was, other issues were found. He has a GI bleed, so he needed to be seen in GI. Well, we have a very large shortage for gastroenterologists in our area. And so, Carly was working very hard with him to try to get him in with the GI doctor, but we were getting nowhere. And she realized when she was working with him that it looked like he might qualify for Virginia Medicaid. So then she pulls Sky into the team and they start working really hard to get him Virginia Medicaid. But even then, once he found access to Virginia Medicaid, he was going to have to go all the way to Roanoke to be seen by a GI doctor, which that's about 2.5 hours from us. It's a pretty far drive, for someone with transportation issues and low income. That's a big ask, and he's going to have to go multiple times. Sky was really able to get in there and to dig deep to figure out why wouldn't his insurance let him go to the GI doctor here in Bristol, which is really, much closer for him. And it had to do with the MCO that he had. They didn't like that it was crossing state lines. So she was able to get him switched to a different MCO and get him into the GI doctor. Needless to say, I think if Brandon had been trying to navigate the system on his own, he would have just given up because there were just barrier after barrier after barrier. And it took experts in this field to really be able to help him. That would have been very hard for him to navigate and probably would have shortened his life and his health outcomes, not to be dramatic, but it really helps people have a better quality of life and to access the care that they need that they might have just given up on, because we've seen that happen time and time again. So thank you so much. I hope that this webinar helps you see the value of community health workers and gives you some ideas about bringing them into your own clinics. I think that's all I have.
Thanks so much, Amy. Love to round out our presentations this morning/afternoon, wherever you're joining us from, by welcoming Lindsay Miller with the Connected Care for Older Adults program. Welcome, Lindsay.
Thanks so much, Megan. Thanks for the invitation to be here today. We're really excited to share about our community health worker pilot we have going in rural Oregon. It's called Connected Care for Older Adults. Next slide. This pilot started in the Columbia River Gorge with support from our region's clinical advisory panel. The model uses CHWs in primary care settings to improve care for older adults in rural areas. We serve patients 55 and older who are referred by a primary care clinician who are living independently, not currently receiving other in-home medical services like home health or hospice. Through our program, our CHWs conduct a series of home visits where they implement 5 connected care protocols, which are based on the 4 M's of the IHI's Age-Friendly Health Systems framework. So what matters, medication, mentation, and mobility. Based on these protocols, the CHWs provide patients and families with information and education, connect them with existing community resources, and flag urgent needs or action with the patient's primary care clinician. Like Amy discussed, our CHWs are fully embedded in the primary care teams. They're employed by the primary care clinics. They can chart directly in the EMR, and they share key information with the patient's PCP and care team. We aim to move patients through the program in about 90 days, so it's not meant to provide long-term support, but really designed to help patients stabilize and make sure that the 4 M's have been adequately addressed. Next slide, please. Connected care is currently being piloted at 6 rural clinics in Oregon, and we're hopeful to expand to new rural and tribal clinics and FQHCs across the state in the coming years. Next slide. Since our first pilot launched at the end of 2022, we've enrolled over 500 patients across 7 rural clinics. On average, our patients receive 4 home visits, and our CHWs make about 10 care coordination calls to patients, family members, and community service providers. Next slide. Over 95% of our patients have a public primary insurance coverage, either original Medicare, Medicare Advantage, dual eligibility, Medicare, Medicaid, or Medicaid only. About 4% of our patients have private coverage and about 1% are uninsured. Next slide. About half of our patients do not have an identified caregiver at enrollment. 68% do not have an advance directive on file, and about a third have been hospitalized, and 50% have been to the emergency department in the year prior to enrollment. So we're pretty confident that we're hitting the right patient population with our services. Next slide. We're also tracking social needs of our patients at enrollment and finding that about 42% require assistance with activities of daily living. 39% are in potentially unsafe situations, which could be related to a physical environment, self-neglect, elder abuse, etc. Over a third of our folks struggle with social isolation, which is a huge issue for older adults in rural areas. And relatedly, about 29% lack adequate transportation. Next slide. We are super proud of our work to help get advance directives completed for our patients. If you've done an advance directive yourself or supported a loved one through the process, you know it is not easy. Our CHWs have been able to increase the number of patients who have an advance directive on file in the EMR from 32% pre-enrollment to 66% post-enrollment. And one of our clinics has over 90% advance directive completion for their connected care patients. Next slide. We're also tracking completion of other evidence-based interventions associated with the 4 M's, looking at what matters conversations recorded in the EMR, cognitive assessments completed, the steady fall risk assessment, a medication review, etc. Next slide, please. We're in the process of collecting utilization data for all of our pilot clinics to really look at whether this program has the intended effect of decreasing hospital and ED utilization. And you can see from this early data a promising and sustained decrease in the rate of hospitalizations and ED events per month, as well as days hospitalized per month. So we're really excited to continue looking into this data as it would clearly strengthen the economic case for expanding this model. Next slide. We ask patients and clinicians for feedback about the program. One patient told us, "I was able to stay in my residence without fear of eviction and was able to have the landlord update many of the things in the home that were worse for wear." This particular patient had older carpet that was wrinkled and causing a real trip hazard for them. The community health worker gave me my peace of mind. And a clinician shared, I absolutely want to see this program thrive and grow in order to help increase access to services for some of our most vulnerable patients. I love it. Next slide. So what are we learning? Through this pilot effort, we're learning that connected care is a viable model for improving primary care services for older adults in rural settings. For less than $2,000 per patient, it seems to have meaningful impacts on quality of care and cost-saving measures like advanced directive completion and reduction in high-cost utilization. We're excited to partner with our state health authority to scale this model to new rural clinics through the state through the Rural Health Transformation Program. Next slide. We have truly incredible partners who have supported our work over many years now. We're forever grateful for their support and investment in this concept. If you'd like more information, you're welcome to visit our website, connectedcareforolderadults.org. And again, thanks for the opportunity to share our work.
Thank you so much, Lindsay. Thank you to all of our presenters. I'd like to invite you to all come back on camera as we move now to the question and answer portion of the webinar. We have already received a lot of great questions. As you'll see in the Q&A feature, we're doing our best to answer as many as we can. If you haven't already asked your question, I encourage you to ask it now by clicking on the Q&A icon at the bottom of your screen. So I think Annie, you're on. Amy, welcome you to come back on camera. And I'll first just open it up that I think we've received a lot of questions, both from registrants before the webinar and during the remarks, about the topics of recruitment, of training and retention. And there was a question shared in the earlier about just can you speak to whether rural communities are finding it hard to find or retain CHWs despite them being so critical? So I'd like to open that up to the group to describe some strategies or ideas that you found to be effective to really support recruitment and retention to help identify the CHW workforce to really meet the needs of rural communities. And Amy, I saw you responded kind of talking about looking to find natural helpers. And I'm wondering if you could kick us off by talking a little bit more about what that's looked like in your experience.
Yes, I will say that hiring for community health workers is very different than any other type of role I've hired for. And there have been many. You don't just go and put it on Indeed and then all these community health workers apply. I mean, maybe that's the case some places, but we really didn't even have community health workers in this area until, about 7 years ago. And then it really, ramped up more in 2020. But there still are not a lot of trained community health workers in our area. So when we hire, we really, we still put it on Indeed and run an ad, but we also we look for people that we already know who are natural helpers in the community. We're very careful with the wording that we use, that this is a different type of position. We're really lucky that we work with Impact Care, so they give us lots of training and guidance to help us with the hiring process, which is really awesome. But yeah, I learned really quickly it is not like hiring for other positions because you're looking for someone who is trusted in their community and who is a natural helper. And that is one nice thing about being in a rural area is we all know each other really well. So often it's someone possibly that you already know or you already know of, and you're going to be reaching out to them. They may not be looking for a job. They may have a job that they think they love. They may not know this is even a job. And so besides Bree, all of our community health workers, this was their first time being a community health worker. They were trained. They have been heavily trained because they've gone through the state training and through impact training. And so they've been trained on the job and received all of their hours on the job. And it has worked beautifully, but you have to have a different mindset than you normally do when hiring.
Thanks so much. Bree, welcome you to add any reflections or insights from your experience.
Absolutely. And I'll just kind of piggyback on what Amy said. The hiring process is very different when you are going through the interview process, it's really good to do a scenario of some sort, just to gauge people's empathy. Make sure they are the natural helpers. Make sure that they do have that listening ear, that they're naturally kind. They want to really truly be community minded and help everyone. That's really important as well. And then I would say, as training goes further, when you're doing home visits, seeing how they react to the different home situations, watching facial expressions, body language. That's so important. Not necessarily that once you've hired on that, oh, you can't be a CHW, but being able to use that as a teaching moment if there are issues, and being able to talk about it openly is really important. And finding someone that takes correction well, not so much, I wouldn't even say correction, but just communication well. Hey, when we go in, let's make sure that our facial expression doesn't show what we're really feeling about the situation. Being able to just do those little things is really important. But hiring does look a little bit different, a lot different for CHWs for sure. But just, yeah, those natural helpers, that's what you're looking for.
Wonderful. Annie.
Yep. And I'm sure Amy and Bree have a lot more to add here too. But I think the other piece is just thinking about retention and how critical that is for sustainability. And, the things we think about are just what are the workflows or other supports to support CHWs once they're in those roles. So thinking about, what those tools are to really allow people to focus on working with the patients. And then what are the guardrails to make sure that CHWs feel supported, like supervision, career ladders, a lot of the things that Bree spoke about are part of that accreditation process.
Thanks so much. Lindsay.
Thanks, Logan. I'll just add quickly, our Oregon State does have a state recognized CHW certification program. And so one of the things that we've done to make it a bit easier to recruit folks is not required that certification at hire, but supported our CHWs to complete that certification, which is 110 hours while they're on the job. And that's been a really a good strategy for kind of increasing the potential field of applicants. I would say recruitment and hiring is the challenge for us, which we knew would be the case, but actually retention has been, we've been really successful. All of our folks have stayed in the role over a year. We've only had 2 folks turn over and 1 retired. So we've felt really lucky to have found people who are really passionate about this work and who enjoy it.
Wonderful. Thank you all. There was also a question about CHW associations and trying to understand how to find your state or your regional CHW association. And I'd like to follow up on that and Bree, ask you to speak to suggestions for whether it's states, state staff, whether it's providers, CBOs, of how to engage with CHW associations and best practices to really engage CHWs in designing new programs.
Absolutely. That's a great question. So to get connected to a state association for CHWs, I definitely think if you are in a state that has one, you should be connected, whether you are a community-based organization or just if you are a hospital system, whatever it is, get connected to that state organization because they're going to know what's going on as far as sustainable funding. They're going to be working on all of that boots on the ground things of thinking about sustainability for our entire workforce. So it's really important that you're connected to your state organizations. For us specifically in Tennessee, you can actually just get on tenchua.org and send us a message. You can become a member, which if anybody wants to do that, we would love to have you. A little push for our membership program. But definitely you can get on there and become a member. And that means you're going to get all of the updates that we have. You're going to get to be part of our membership program, which is going to have like monthly meetings, day on the Hill, all of those fun things, and a summit. We're going to have all of those fun things coming, but each state has different things like that. I live in an area where I'm working for Tennessee. I live on the line. So Virginia, Tennessee. So I actually have also been very involved in Virginia. And it's the same thing. You can get on their website. And most of the time, if you don't know the website link, you can just click in Community Health Worker Association in the state and it'll pop up. You can also go to the National Association of Community Health Workers website, and it does have a list of associations as well. but definitely can do things like that. And what was the second half of your question, Logan? I am so sorry. I went on a tangent.
That's great. Just if there's any other kind of best practices for really meaningfully engaging CHWs in program design.
Absolutely. So I mentioned in the beginning of my presentation that I've been part of building two programs with two very different programs for different places. And bringing CHWs to the decision-making table is imperative to how your program is going to come out. Because we know beyond what you can understand what CHWs need as far as support, as far as our everyday look. We know we can tell you from the beginning, hey, my day doesn't look the same every single day, where other people might clock in and they have a routine and they go through and they do the routine every day. I might not get to do that. I might clock in and get a phone call from a patient and everything I have planned for that day completely changes. So they have to be at the table because they have an understanding of the needs that they have. If you're building something from the ground up, if you can't have someone who's been a CHW before, then you want to bring people in that have been doing that type of work and try to connect to as many people that have CHWs that have that knowledge on how it works in order for it to be super successful. Now, I'm not going to say everybody's will not be successful if you don't have that. When I started, I did not have the role of a community health worker. Like I didn't have that title at the end of my name when I first became a CHW. But I'd been doing the work almost my whole life, just didn't realize it. But when I finally figured out, when somebody whispered in my ear, which actually was the impact model at the time, it was Shreya. She was like, hey, CHWs are different because you get to work on what's important to the patient and you're working on their lives and getting them happier and healthier. And I was like, oh my gosh, that's like the whole point. I can do this. Like, that's so amazing. So it's just making sure that you have someone there that'll keep you grounded and keep that the point. We see a lot of places that try to over medicalize our position. And there's nothing wrong with having the knowledge. There's nothing wrong with knowing how high blood pressure works and how diabetes works and how mental health and substance misuse. That's great when we have all of that knowledge. But to put us in positions where we can't do our job, which is to literally get them to a happier and healthier spot, that's dangerous and it's not going to be successful. But if you put us in a spot where you're like, you have this knowledge that you can give them while you're working on what's most important to them, then that's a game changer. That's what changes everything CHWs do. And having them at the table to keep you grounded and to remember that is important. And we have that whole saying, nothing about us without us. So when you're making decisions, having us at the table is very important.
Thank you so much. And we're getting a lot of great questions. We're going to just keep moving through them. Um, some of your presentations referenced some of the challenges related to travel and transportation, which can be especially challenging in rural regions. And so, Amy and Lindsay, I'm wondering if you could speak to how your respective programs have really addressed some of those challenges related to travel time and transportation costs.
Sure. It's such an important thing to talk about. We've yet to find a billing mechanism that would cover travel time or mileage for our CHWs. And in our rural area, we have CHWs who are traveling 50, 60, 75 miles one way to reach patients who live out in super rural areas. You can imagine if it's that hard for our CHW to reach them, how hard it is for those folks to get themselves to a clinic for care. So it's, I think, back to that policy question of, really making sure that the policymakers understand those limitations, that it is not viable to ask folks to serve rural areas, especially through home visits, if there's no mechanism to pay for mileage.
Yeah, I'll chime in too. So far we've been grant funded and we've been able to build in mileage into the grant. So that's always something we've written in. But it is something, as we move forward and we move away from grant funding to other, sustainability models, it's going to be hard if that isn't considered. We have talked about if we don't have enough funding, would we have to restrict the service area, while we serve 21 counties, would we have to restrict the service counties to be smaller for the patients who are referred to community health worker? We haven't had to do that. We hope we don't have to do that. But that would be something that would have to be discussed because, like she said, some people live very far away. So the mileage could quickly add up. So that's something that definitely needs to be addressed as we move forward with policymakers and funders that, getting to these patients is very critical. There's no, a home visit. Every meeting with the patient doesn't need to be home visit, but it is really eye-opening. That's when we've learned some of the most important things about our patients that no one on the care team knew that are very critical to their care. So that is, something that will be another sustainability issue, especially in rural areas.
Well, Lindsay and Amy, both of your answers, I think, tee up a question on another topic that's probably the most asked area, which is related to sustainability. So Annie, I'll start with you here and welcome others to chime in. There's a lot of questions about kind of the landscape of sustainability. So there's questions about kind of how much we're seeing reimbursement under Medicaid and Medicare. There's questions about having CHWs in a dual role, potentially as a sustainability strategy. And you mentioned in your presentation about really being mindful about ensuring sustainability in program design. And I think this question about travel and transportation really gets to that. What are the challenges of having a CHW program be sustainable? So I'm wondering if you can kind of speak to, it's a big topic, but some of the kind of key considerations that you think should be top of mind, particularly for state audiences that are thinking about CHW sustainability opportunities, and what are opportunities in this current moment when thinking about expanding CHW services in rural areas?
Yes, happy to. Thank you. So I think there are a couple ways to approach this. Megan nicely teed up that historically these programs have been funded through a multi-pronged strategy, historically grant related, but we are seeing new opportunities unlocked. And so I think the first thing to really think about is what is available in your state. And from the program leader perspective, with your population that you serve in mind. I also think it's helpful to be thinking about a broader set of strategies and typically still multi-pronged. So first, reimbursement, as you all said, over half the states cover some Medicaid billing for CHW services, and Medicare now pays for some CHW services. So that obviously is one pathway that folks should be thinking about and trying to unlock. As I did mention, though, when you design programs and policies, they must be set up to actually allow those providers delivering services to bill. I saw a comment in the chat about CBO billing, given we know CBOs are a main employer of CHW services. So states need to be thinking about those factors, who's employing the CHWs, where their services are delivered, as they develop policies to ensure that folks can actually access those services and that reimbursement can flow. As I said earlier, reimbursement alone is just not enough when we look at the rates, though. So really need to be expanding sort of the approaches we're considering. And I would say the other two, big opportunities I see are states working with both providers and payers. So when we're thinking about payers, are there opportunities to include CHW in care delivery, like including Medicaid managed care programs to make CHW services available to enrollees? So really thinking about states engaging payers in that way. And then value-based payment initiatives that can be done with either payers or providers. There are ways for states to consider strategies that integrate CHWs into those models through provider incentives or other strategies that make sure providers participating in delivering those sort of comprehensive approaches do embed CHWs in their care teams.
Thanks so much. There's a lot a lot more detail in some of the resources that Annie provided, and I appreciate that we've been trying to answer some of those specific questions that people have shared in the Q&A as well. At the end of this, we'll also share our contact information, and if there's any further questions, really welcome any outreach and follow-up from participants. One other question that came in that I'd like to pose to the group is on strategies for engaging providers and increasing buy-in from senior health system leadership, particularly to really support the work that CHWs can play on interdisciplinary teams. So welcome anyone who'd like to answer that question to jump right in.
I'm going to volunteer Bree to answer that question. She was very instrumental in helping us to get the buy-in at Healing Hands when she was still here from our providers. I'll add before she speaks, you have to be patient. Seeing is believing. And that, so it takes time. It takes time for everyone to really understand what is the community health worker role and why is that valuable to the provider and to the patient. So I'm gonna let Bree jump in if she doesn't mind me volunteering her.
That's okay. I think I was typing an answer to someone else, so I might not have got the whole thing, but I think I know the gist of it. So I know that for us, when I was with Healing Hands, for sure, it was making sure that we were gathering stories, not just data. Data was important too, and Amy was a lifesaver when it came to that because data was not my forte. So she came in and was trying to take care of that part for us. But me capturing the actual story about where someone was and then when I left them where they were, that was so important. But not just the, oh, well, here they were. And then when I left them, they were so much better. But also the in between, what the magic, the mushy stuff that's really hard to capture in data. So the part where a patient was, well, I'll give it a really great example. I was told a patient was non-compliant. They're non-compliant. We've tried and tried. We can't do anything with them. There's nothing we can do. See what you can do with them is pretty much what it was said. That sounds like our doctors are jerks. They're really not. They were just at their wits' end. They were like, we don't know what to do with them at this point. So I went to meet with the client, sit down with them, and I was like, so what's going on? Walk me through your day. Like, how do you take your medications? What does this look like? And he brings out the most massive pill bottle I've ever seen, and he dumps it out on the coffee table, and he starts picking out one of every kind of pill. And he says, I take this every morning. I said, okay, but what is this? And he said, I don't know. I'm dyslexic. I can't read. I said, oh, okay. So when I started working with him, I figured out, of course, he was dyslexic. We went to the pharmacy because I was like, I have no idea what this medication is. We go to the pharmacy, we figure out, hey, we need to separate this medicine. This is how he needs to take it, get a printout of how he's supposed to take it. We get him a monthly organizer that has morning, afternoon, evening. The guy had been taking his medication for diabetes that was supposed to be like 2 and 3 times a day, just once in the morning. He had been taking his sleeping pill in the morning. Everything was in the morning time. So he wasn't seeing the changes that he needed to see because he wasn't taking his medications correctly. So taking that story and being able to say, it's not just, oh, I worked with him, he wouldn't take his medicine, I stopped working with him, he was. It's saying, there was a problem in between where everybody was writing him off as non-compliant. But as a CHW, I got to go home with him. I got to sit in his comfort zone where he was able to open up and say, I'm dyslexic. I can't read my pill bottles. And this is the problem. And I was able to help him figure out how to fix that. And then his next doctor's appointment, they're like, wow, everything's so much better. Like, he's sleeping. His diabetes is under control. Blood pressure is doing great. This is awesome. So it's showing all that mushy stuff in the middle that we're able to try to figure out. And then, of course, the other mushy stuff was that he was lonely. So guess what? We started going to the local senior center and working out with our friends and meeting new friends. All of those things completely changed his whole way he was doing life because somebody was willing to go home and listen to his story. So being able to capture that whole thing, I had to learn that. That's not something that I had initially that I was like, well, what do we need? But then being able to retell it. So when you're working, trying to build programs and you have CHWs that are doing great work, have them start writing down details, like what really made the difference here, what was really the pivotal point that changed everything, and then help them build a story that they can come off with and tell people that gives buy-in to your program. I was able to stand up, and of course, Healing Hand gave me so many opportunities to stand up and sit in community spaces where I was able to tell people who were giving money to Healing Hands, hey, this is what we're doing to make a difference in the community besides just being a clinic and a dental clinic. We are going out, boots on the ground, and sitting with our community members, loving on them, seeing what they need to be happier and healthier. This is what we're doing to make a difference. So really sit with your CHWs, teach them how to do that, and you're going to have buy-in because people love the heartfelt stories. With that data to back it up, you need an Amy, because that was not my forte, the data to back it up. But those stories really is what people hang on to.
Thank you. Thank you, Bree. Thank you, Amy, for perfectly teeing that up. Lindsay, I'm wondering if I'm thinking about as Connected Care, has really partnered with a range of different healthcare providers. If you could also speak to this question about provider buy-in, provider partnerships, and some of the lessons that you've learned there.
Yeah, absolutely. It is a fantastic question. I would say to synthesize our learnings, every clinic is different. Every clinic culture is different. Patient populations look different across the clinics that we've engaged with. So really respecting those differences and working with clinics to understand what's going to work best for them has been really important for us. We've worked with some clinics who have had CHWs as part of their teams for decades, and we've worked with clinics who've never even heard, well, or who have never employed a CHW role in their clinics. And so across that spectrum, it has been really validating and rewarding to see how much the clinicians appreciate the role that our CHWs are able to play. It helps them to feel more supported, to be able to provide good care to their patients. And so whatever we can do, and I will say we've got two incredible physicians on the call here today who have been co-designers of this model, who have been real champions and advocates. It's been so beneficial to have their physician voices to be able to communicate directly to other clinicians and help explain why this is important and why clinicians should think about partnering with CHWs as key members of the care team.
Thank you. We could probably go on for quite a while longer answering these great questions. Unfortunately, we are at time, so we'll bring our slides back up and just share a little bit more information before we wrap up today. First, I would just like to share some resources. These will be in the slides that you'll receive. This whole presentation will be available for you to watch and share with any colleagues. We encourage you to check out these resources. And if you have great resources that we should know about, to please send them our way. We can go to the next slide. We include some background for the information that was shared today, and then we can go to the next slide. And I would just like to first thank our presenters, Annie, Bree, Amy, and Lindsay, for sharing your insights with us today. We tremendously appreciated it. And I would also like to thank the Seven Foundation Collaborative for supporting this webinar. As you know, as you are designing and refining CHW programs, please feel free to follow up if there's any other questions that didn't get answered, or if you have any questions or ideas coming out of the webinar. Emails for my colleague Megan Terrell and myself are on the screen. And finally, you'll receive the evaluation survey that's also in the chat. We would really appreciate if you could fill that out. It'll help us know how to best design webinars and other communications in the future. And we really appreciate your feedback. So again, thank you to our presenters for the great discussion today. And I hope everyone has a great day. Bye.